Today's topic is a national registry of red blood cell antibodies. So this session is presented by Dr. Gagan Mathur, Medical Director for Children's Hospital Los Angeles, and Dr. Jay Menitov, who's the CEO of JEM Consulting and the former CEO, Medical Director of the Community Blood Center of Greater Kansas City. Dr. Mathur is currently serving as the Medical Director of Transfusion Medicine at Children's Hospital Los Angeles. He holds an academic title of Associate Professor of Clinical Pathology at Keck School of Medicine at the University of Southern California. Utilizing his formal training and interest in business management, informatics, data analytics, and healthcare administration, Dr. Mathur strives to provide effective and efficient patient care. And then Dr. Menitov serves as the Associate Editor of Transfusion, chaired the HHS Advisory Committee on Blood and Tissue Safety and Availability, and is an AABB past president. Dr. Menitov's academic interests include transfusion safety, blood donation, and sustainability of the U.S. blood system. He's the author or co-author of more than 170 journal articles, textbook chapters, and other publications. So please join me in welcoming both Dr. Mathur and Dr. Menitov.
Thank you very much, first of all, WellSky, for inviting me to present here, and I'm really honored to be sharing the podium with Dr. Menitov, so really excited to be here. So the things we will be talking about today, so Dr. Menitov and I will be presenting slides back and forth. So I'm going to start with general introduction for what are alloantibodies, and then importance for having an antibody registry. Dr. Menitov is going to talk about regional antibody registry, which exists for many years. Then I'll share experience of using that registry. Then we'll go back to Dr. Menitov. He's going to talk about how that can be scaled up for at national level. And then I'm going to share an initiative that is out there for that. OK, so starting with the alloantibodies. Antibodies are proteins, immunoglobulins, which are formed in response to a foreign antigen when you're exposed to. We all know about the ABO antigens which are present on the red blood cells, and the ABO antigen which you don't have, you have naturally occurring antibody against that in your blood. So if you have blood type A, you have anti-B antibody. In addition to those ABO antigens, on the red blood cell, there are a bunch of hundreds of other antigens out there. We have heard about CAL, Duffy, KID, MNS, bunch of other out there. Those antigens, we don't all have all of them. So the ones which we don't have, and if we are exposed to those antigens, we form antibodies against them, and those are called alloantibodies. And the exposure that happens is through most commonly transfusion. For females during pregnancy, they can be exposed to these antigens from the fetus, and they can form antibody against that. Then other way of exposure to these immunogenic material is through needle sharing and injections and transplantation. So these antibodies, how do we identify these alloantibodies? So in the blood bank workup, we perform ABO typing, ABO and RH typing, and an antibody screen. So the antibody screen, which is also called IAT, indirect agglutination test, where we take the patient's plasma, which might have those antibodies in there, and then we mix that with the screening cells, which are the test cells which have known antigens on their surface. And if the antibodies bind to those red blood cells, the test screening red blood cells, they will coat it. And then we will add AHG, anti-human globulin, which is antibody against antibody, and that will help causing the agglutination. So if there's agglutination, you can see it, and we will say those antibodies are present. And when a patient needs blood transfusion, we will identify the units which will lack those antigens and give those units to the patient to avoid hemolysis. So which is the clinical significance. Why do we do that? So if we don't match those antigens, the antibodies that the patient has, and we don't match the units which lack those antigens, then we put the patient at risk of having immediate or delayed hemolytic reaction. Those antibodies will coat the red blood cells and can activate complement and cause the hemolysis right away, or those coated red blood cells will be taken to the spleen and will be hemolyzed later on, leading to delayed hemolytic reaction. Also, in a pregnant female, if we don't identify those antibodies, we put that patient at the risk of having delayed hemolytic disease of fetus and newborn. And for patients which need transfusion, we have to honor these antibodies, and this finding the compatible unit needs extra time and effort. So these are the clinical significance of why we need to take care of these antibodies. So now talking about how common are these antibodies. So the prevalence in general transfused patients is around 3 to 5%. But this prevalence varies with age, sex, and the underlying disease. So as you can see in the chart on the top, with age, the prevalence of these antibodies increase because you're more likely to be exposed to these antigens with age. The other thing which contributes to the prevalence is the sex. Female patients are more likely to be exposed to these antigens because in addition to transfusion, pregnancy is another exposure. So female patients have higher prevalence of alloantibodies. And the graph at the bottom, you can see for each age group, female patients usually tend to have higher prevalence except for the really young age. But a really important contributing factor to the prevalence is the underlying disease. Patients which are more likely to be transfused, the patients which are chronically transfused, they will have higher risk of forming alloantibodies. So as you can see in this chart, so the patients which are commonly transfused chronically, sickle cell patient, thalassemia patient with hematological malignancies like myelodysplastic syndrome, aplastic anemia, these patients will have higher risk of forming alloantibodies. In sickle cell patient, the prevalence could be as high as 40 to 50% of these patients will have alloantibodies in their plasma. And these patients are at higher risk to have these antibodies and at high risk of having the complications associated with these antibodies. Another important phenomenon to know about this alloantibody is evanescence. What it means is these antibodies decrease in their titer over time, and they might completely disappear. And almost 60 to 80% of these antibodies over time will disappear. So we have exposure, antibodies form, then they will slowly disappear, and then when you are exposed again, they might come back. And the rates of evanescence, like it also depends on the time and the type of antibodies. So most of the antibodies will stay by the end of the year, but almost 30 to 40% of these antibodies might disappear over time. Or by 5 years, 60 to 80% of these antibodies might completely disappear. And on the chart there, the colored one, you are seeing various antibodies. So various antigens have different immunogenicity and how fastly those antibodies form and how quickly they disappear. So the one in the pink is the anti-M. So the anti-M, almost half of the anti-M antibodies will disappear within 6 months. So the x-axis is the time in days. So almost 400 is like around a year. So by 6 months, anti-M, half of the anti-M might disappear, and the other antibodies, half of them might disappear over 5 years. I was surprised in this study, like the typical antibody that we talk about that disappears is the KID antibody, JK, just kidding, which is known for, like it comes and it disappears. So, which is not shown here, but I'm quite sure that follows the pattern that anti-M or even might disappear even like within few months. The anti-M and anti-JKA might be follow similar trend. The other important thing for evanescence is, because of the evanescence, like half of these antibodies, 60 to 80% of these are disappearing over time. So when we are doing the testing, the patient might have antibody previously and now it disappeared. So the actual prevalence of the antibodies might be much higher than the 3 to 5% that we are talking about. And especially in the patients which are chronically transfused, this leads to poor outcomes in them, increased morbidity and mortality, because they might have an antibody which disappears, and we think it's not there, and we don't honor it, and these patients will have another exposure and leading to poor outcomes. So the poor outcome, it's again hemolysis, which we're talking about, and again acute as well as chronic hemolysis. So we talked about higher prevalence. So because these antibodies disappear, the actual prevalence might be much higher than they disappear evanescence. And then the third important point which contributes to these morbidity and mortality is care fragmentation, which is dispersion of individuals' healthcare across the systems, lack of collaboration and standardization of the care. We all know in our day-to-day work, sometimes multiple physicians, multiple teams are taking care of the patient in the hospital, and sometimes we don't have good collaboration between those people in the same hospital. Think about a patient which is going to different hospitals, going to different infusion clinics or other clinics, and if those teams are not working together, not communicating, they will they will not get the proper care they need. And that is one of the important contributors to low quality of care and negative health outcomes. And companies like WellSky and other LIS and EMR companies, they are actually working on this care fragmentation because their EMR and LIS, they try to communicate the medical record between different hospitals. So shout out to WellSky. Okay, so, and these chronically transfused patients, because of all these things, higher prevalence of antibody, evanescence, and care fragmentation, these patients get poor care, and that leads to poor outcomes. And so let's see how prevalent is this. So now we're going to focus more on the sickle cell patient because these are the patients which have been more studied for these kind of care fragmentation. So this study talked about that almost most of the patients, almost 60 to 80% of these patients were seen at more than one hospital. And as you can see in the graph, like more than 12 sites. Some of these patients are seen at 9 to 10, more than 10 sites over a 2-year time period. Another study in California found 78% of these sickle cell patients seen at more than one site. A study in Connecticut, 73% of these sickle cell patients seen at more than one site. And in that study, they also talked about most of these patients are alloimmunized. We talked about 40 to 50% of these patients have antibodies. And most of these have evanescence, that most of these antibodies had disappeared. And then on top of their care fragmentation, so which is a bad combination. So fragmented care, antibodies which are disappearing, not identified at one center and identified at other center, no communication, that leads to poor outcomes. This chart again showing here, I don't know if we can tear. So they studied around 7,250 patients. Like the patients which are just seen at one hospital, the prevalence of antibody was around 3 to 5% that we talk about. But the patients which were seen at more than one site, 2 hospitals, the prevalence of antibody was almost a double. So like one hospital finds that antibody, other hospital does not find it. And this chart this table over here is just showing one hospital versus the other hospital, how the antibody was identified at one hospital and not identified at the other hospital. So again, what is it leading to? Leading to hemolysis. I've repeated that multiple times. So what can we do to prevent this from happening? So reducing the risk of alloimmunization, that would be the first thing. So some of the places, and for some of the patient population, we can do prophylactic antigen matching, that we identify the patient's genotype or phenotype, that what kind of antigens they have on their surface and which they don't have, and the ones they are lacking, we try to provide the units which don't have those antigens so that they are not exposed to those foreign antigens and they don't form antibodies. So for most of the chronically transfused patients like sickle cell patient, thalassemia patient, we try to match CE and Cal. Some places, depending on the resources, they will match the KID and Duffy. So that's one of the things that you can do. The second thing is use red blood cell transfusion carefully whenever it's needed. It's easier said than done for the chronically transfused patients, sickle cell patients, thalassemia patients. They will eventually need transfusion at some point. So these patients are exposed to multiple transfusion even when we try to give the blood products only when it's needed. And the third point, ideally it will be nice to know which patients are responders and which are not responder. Not all sickle cell patients, not all thalassemia patients form antibodies with exposure. Some of them they do, some of them don't. Unfortunately, we don't have a good way to know which ones are a responder and not responder. At some places, one thing that we do know is that if a patient forms one antibody, they are at much higher risk of forming more antibodies. So some of the hospitals, they might not do prophylactic matching or do a limited prophylactic matching for a patient which is not forming antibody, but once they form one antibody, they will do extended antigen matching for them. The second and the third way to manage this is reduce the risk of missing the detection of those antibodies and reduce the risk of exposure to these disappearing antibodies. So the first one is you do a follow-up antibody screen on these patients. Anytime a patient needs blood transfusion, we have to do a type and screen, which has to be repeated every 3 days if the patient is going to need the blood transfusion right away. But for these patients which are exposed to a unit one time and they don't need blood transfusion for the next few months, they might form an antibody between the time period which might come and disappear. So some of the places might do a regular type and screen every month or every few months just to make sure that if they develop any antibody and if did it disappear. So that's one of the things you can do. And the other things which we talk about for the second and the third point is avoid multi-site transfusion. Again, easier said than done. Multiple patients have various socioeconomic reasons why they go to different healthcare providers, insurance, and a bunch of other things. So we should try to avoid multi-site transfusion, but whenever possible. Then the other 2 points are a thorough transfusion history and reliable inter-institutional blood bank communication. Most of the people who work in transfusion service, that's one of the things that they do whenever there's a new patient. We try to ask the providers to ask them about their transfusion history. Have they been transfused before? Because if they have been transfused before, they might have a risk of forming antibody. And if they know, yes, they have been transfused, which hospital they were transfused at, and we try to contact them to get that history. So how do we do that? We have a very high-tech way of calling them, and we ask for the information, which is, in today's time, like that's the most inefficient way of doing it. And again, that's what contributes to the fragmented care, because some hospitals will be very good at doing that, and other hospitals might be nice enough to share the information. Some people might not get that information easily out from the other hospital. So this is the inefficient way of doing this is contributing to the fragmented care and poor outcome in these patients. So what could have been done? So as we have talked about, chronically transfused patient, multiple antibodies, 40 to 50% of them can have antibodies. 60 to 80% of these antibodies can disappear. So wouldn't it be nice to have a system where we can reach out, have an antibody registry or database, which we can tap into to get that information? So now I'm going to hand it over to Dr. Manitov, who is going to share his experience with that.
Well, thank you. So what we did here in Kansas City 14 years ago was really to build on what you just heard. So Dr. Mather described antibody evanescence, the risk of a delayed hemolytic transfusion reaction, fragmented care, and what sophisticated information technology can do. And so what we did 14 years ago was put together an antibody registry here in Kansas City. And we really did that based on what you just heard. We did it in conjunction with predominant, prestigious pathologists at various hospitals in Kansas City through our medical advisory committee, and came up with a system that I'll explain in just a few moments. Went live in June of 2008. And it really was a fulfillment of something that had come up when I was at the blood center in Milwaukee many years before, so-called dial an antibody. And I'm glad Dr. Mather had the slide of a telephone with a dial, because that tells you when we thought about it and how long ago it was. And you couldn't do it. It really was unworkable based on lack of good technology. With the internet and with modern technology, you could do this. And you could do it especially if you were in a region with a single blood center, a single immunohematology reference laboratory, a single point of entrance to get information about patients with alloantibodies. And the other part of it was we did a little survey and got some information from actually Blue Cross Blue Shield, telling us that of insured patients, 4% or so under 65 years of age received transfusions at more than one hospital. National data showed that it was significantly higher among Medicare-age patients. And so we put the system, the registry together, a secure web-based system, and started entering patients for whom we had data through the blood center's immunohematology reference laboratory. And we used the business associate agreements we had with hospitals to address concerns about HIPAA. And we were successful in launching it with those types of backgrounds. For the registry, we included patient names, their birth dates, the ABO-RH type, the antibodies that were identified, specific comments related to that patient, and whether there were any specific transfusion needs. At the hospital end, the hospitals had unique identification numbers and passwords, and then access levels were put out based on the need for who was getting into the system. So at the blood center, we had an administrator, and we had the IRL users who could put information in. Hospitals, each of the ones who were participating had a hospital administrator, and the various techs had ID numbers that they could use as well to enter into the system. And in terms of putting it together, this was 15 years ago, but the costs were very modest. We estimated that the legal fees back then were about $3,000. The web design with a local web designer was $11,000. I can see some of you laughing at these costs, but I think they were legitimate back then. And the staff time, you could put any number to, but we roughly estimated it was about $8,000. So relatively modest cost to put together something that we thought was relatively important. And then we reported the first year experience in that article that was in Transfusion in 2010. So in the first year, there were about 1,800 patient records in the database, and 4 cases were identified who potential delayed hemolytic transfusion reactions were prevented. One of the patients had a history of anti-Kel, C, and V, and the current antibody screen was negative, as Dr. Mather alluded to in terms of antibody evanescence. Another had a history of anti-Kel, current antibody screen negative. Third patient had anti-Kel, big E, little c, and only the anti-Kel was reactive. And the fourth one had a history of anti-E and Duffy B, and only the anti-big E was reactive. So we felt confident that there potentially would have been a delayed hemolytic transfusion based on that history. The hospitals were equally as interested in the system because it didn't require additional workup. They could go into the registry and at least know how much of the workup they needed to do or when to send it off to the IRL. One of the hospitals said the workup went smoother, a similar type of comment to the first one, decreased turnaround time, and another was able to get transfusion history or patient's transfusion history from another hospital because they had knowledge that there were problems. There were also 4 patients for whom the antibody registry could have been assessed, and it was not. And 3 of those patients had reactions. So we felt very confident after the first year that this was implemented that it did provide a valuable service. And then we expanded it. Over the next year, you can see the number of patient entries that increased. We had hospitals putting data into the system as well. And at the end of that first year, there were 140 different techs at the various hospitals, 20-some-odd hospitals who were using the registry. So we were pretty confident that we put together something that was valuable and that was working well. And then Dr. Mather will give you some updates of where it actually worked within the last couple of years.
I'm currently at Children's Hospital Los Angeles, but before that I used to work in Kansas City at the St. Luke's Health System, and we routinely use this antibody registry like every day. Like I'm sure like we used to do 10 or more workups every day, and we would use that all the time. And I'm sure we provided great care to the patient because of this, this antibody registry that existed. And we shared one of the examples for how this registry helped us. Dr. Tilzer, who was also at St. Luke's for briefly there, we worked on this case together, and like he put together this case report and involved us. So thank you, Dr. Tilzer, for that. So we presented a case of a patient how this antibody registry helped. So there was this 60-year-old patient who needed a liver transplant for non-alcoholic cirrhosis, and that patient was high risk of bleeding. His coagulation labs, platelet counts were really low, PT-PTT were really high. So this patient comes to St. Luke's Health System, an organ becomes available, and that patient is ready to go for the transplant in a few hours. But then we do our workup in the blood bank, and we find that antibody screen is negative. But we utilized the antibody registry and looked up that this patient had a history of JKA antibody, which is typically known for disappearing. And this patient had a workup less than 6 months ago at another hospital, and that antibody is not now showing up. And liver transplant in general are blurry, and this patient is at higher risk. Many hospitals like would have 6 and 6 red blood, 6 red blood cell and 6 plasma for routine liver transplant, and this patient was identified to be at higher risk. So now with the known history of anti-JKA, which has to be honored, and we have to arrange for a lot of blood products for this patient, so we had to delay the transplant. Lucky for this patient, another organ became available. So this organ, which was already harvested, was given to another patient, and a new organ, which was being harvested, came later in the evening, and by that time, we were able to do the extended workup and acquire more red blood cell units from our own inventory, as well as the local, the community blood centers. We gave 2 units of red blood cell right away to this patient because his platelet red blood cell hemoglobin was, I think, 6 or 7 before the surgery, and then he received another 12 units during the surgery and a couple more during the post-op period. But that was not the only blood products that were given to this patient. He received 31 units of plasma, 10 units of platelets, 8 cryopools, and 20 liters of albumin, and there was cell saver used for that patient too. So if this patient was at another hospital system which did not have all these available right there, the cell saver was not there, this patient would have easily taken more than 20 and 30 units of red blood cells, which if we did not know about the JKA antibody, which the prevalence of JKA antibody is 77%. So almost 77% of the units that were given to that patient would have been JKA positive, and this patient could have had significant hemolysis during the surgery, which when this patient is bleeding like crazy, that would have made the surgery even more complicated, or even after post-operatively, his post-operative recovery would have been, like delayed hemolysis would have made it, like could have caused significant morbidity at least, and even mortality, like the patient could have lost the organ. So thanks to this antibody registry, we were able to acquire those blood products which were antigen matched and provide great care to this patient. So in this case report, we shared this experience saying that this antibody registry, which we have access to, but most of the hospitals in US don't have this kind of registry out there. So we built a case that there should be antibody registry like that out there for for all the patients which receive care in the US. So that was our proposal out there. And then I'll hand it back to Dr. Manitov to talk about how the local registry that is out there, how that can be made at a national level.
So we thought that the recent case would give you a sense of that it really still does work. And there are other parts of the country, and actually part of the world, who have registries, local registries, and the sense being that they serve as a template, a prototype for coming up with a national registry. So in Holland, they have a registry called TRIX, and currently there are about 62,000 reports from 62,000 individuals in their registry, 80,000 antibodies. And then in data that they put together after 2011, they felt that they had a decrease in delayed hemolytic transfusion reactions of about 50%. Now, there were some other things that were done as well in terms of preventative matching and restrictive transfusion practices, but they felt that the registry had a significant impact on delaying or in reducing delayed hemolytic transfusion reactions. In Pittsburgh, they have a centralized transfusion service. They serve 16 hospitals out of one large transfusion service. They looked at their results, patient outcomes, and felt that by using a central transfusion service, they were able to reduce ABO errors, mainly through prevention of misidentification events. In Seattle, look at where they have the blood center essentially served as the transfusion service for the hospitals that they served. And they currently continue to do the transfusion services for majority of the hospitals in the Seattle area. They looked at their records, and they found that almost 11% of patients received transfusions at more than one hospital, so potentially fragmented care. And patients with alloantibodies were much more likely to be transfused at more than one hospital. So again, pointing out that if you have a centralized point of care, you're better off in terms of patient outcomes. When the folks in Pittsburgh and Seattle looked at patients with sickle cell disease, they found that patients received transfusions between 1 and 8 hospitals, with a median of 2. And as Dr. Mather alluded to, the antibody evanescence varies on the antibody specificity, but again, and with varying amounts based on, or time periods based on the antibodies. And they found the similar types of things. But again, with a central point, they felt of reference, they were able to reduce delayed, or at least knowledge, and potentially reduce delayed hemolytic transfusion reactions. So our sense is these regional registries serve as a prototype for putting a national registry together. Clearly, patients with alloantibodies receive care at multiple hospitals. The error rates decrease. But there's also an evolution in terms of the way blood suppliers serve hospitals. Years ago, you would have a single blood supplier for a geographic region. Today, that's changing where there are multiple blood suppliers for a region, multiple immunohematology reference laboratories, multiple inputs, fragmented potential care that could be avoided by a national registry. So our sense, again, is regional registries, the one in Holland, serve as a prototype for putting a national registry together. Dr. Mather has been involved in some of the proposals to put a national registry together, and he'll explain that to you.
So there are multiple ways this could be done. It could be done at a national level, at the government, NIH, or somebody else can do it. But one of the proposals that's out there, I'm going to share that. And the reason why we need to have that, again, saying the same thing again, that to improve patient safety and outcome, reduce the hemolytic reaction in the patients which receive fragmented care seen at multiple hospitals. And it will also save a lot of time and workup for the hospitals with the hospital transfusion service. So one of the proposals that's out there is called red blood cell alloantibody exchange. So this project is started at Yale School of Medicine. So Dr. Hendrickson, Dr. Tormey, Dr. Hauser, these are the physicians from Yale which came up with this proposal. So what they have done is they have developed a cloud-based registry where they will like to various LIS system to provide information, exchange information, like they put the input their results, as well as the other hospitals can extract the data from there to get that information out. So this is an idealized view which they would like to see, that this is a cloud-based registry where all the blood bank LIS system, the WellSky, Cerner, Hemolytic, Sunquest, Soft, Meditech, these all change the information. Like they provide the information, like the workup that is done at the transfusion services using these LIS system, they put in their result. And the other hospitals which are using the same LIS system or a different LIS system, they are able to go in there and extract that information out to use for themselves. It is a really great concept, but it's not easy to implement. There are a bunch of questions and concerns out there. So this group, I'm just part of that. Like when I published this article with Dr. Tilzer and Dr. Manitov, they were also working on that, and so they were like, oh, you published something similar, so you should come and talk to us about this. So I just go sit with them and listen to them, but I have not been to the business meetings with these LIS people, which have different questions and concerns. So I think Soft has agreed to participate in it. Cerner has done that too. Other LIS systems are still in communication and in contact with this proposal to see how this can be implemented. So ideally, as I said, there will be exchange information that the antibody workup is entered by the techs, and on the other side, the techs can extract that information again, and it will be at the hospital level. They decide how they want to take that, accept that result as. If you trust the results, like in Kansas City area, we knew if the workup was done at the community blood center, which was running this registry, we will accept that results right away because we trusted them. But if the workup was done at a smaller hospital somewhere else, we might still take that into consideration, but we might not add that to the permanent patient history. It might just go as a exchange antibody or something else. Like you might label that as external result and use it cautiously. But if you trust the result, then you can use it right away. So that's the basic proposal that's out there. In summary, various organizations, ABB, ASCP, they have supported this kind of initiative. By the time we published this article, at the same time, ABB survey was sent out to all the hospitals that, in theory, if this was out there, would you use it? And predominantly, all hospitals said that they would like to use something like that. But again, it's a really complicated initiative. Requires a lot of input from regulatory agencies as well as different hospital systems and how they do their day-to-day activities. So work in progress, but hopefully we'll have something like that out there for all of us to use, and we will continue to provide great patient care to our patients. Okay, that's all we had. Any questions or comments, concerns?
I'll walk around. Peggy, did you have a question?
Yeah. The solution consultant for our analytics approached me with the alloantibody exchange. And her concern is, of course, the patients and their identity. And what they proposed, what she proposed initially was, would they accept an antibody report initially from us as a source of a feed? But she's worried about the patient identity.
That's true. You mean can we share that data or not?
Yeah.
So right now we are doing it over the phone. So we call somebody and just give them name and MRN number, date of birth, not MRN, date of birth or some other, and we are accepting that, but we don't want to do it in a proper way. So it's a genuine concern, but we already do it over the phone. And sometimes we are exchanging that information over the phone without knowing that patient has signed the release of information documents or not. So we are doing it in a less regulated way right now, to my understanding.
Yeah. It's a little more than that. I think so let's say Bonnie Norris goes to Providence Hospital in Portland. If she goes to OHSU, they both send to an exchange. Who's responsible for saying that Bonnie Norris is that Bonnie Norris and then putting that data together?
Right. So now we have to come to that. Should we have a national medical identification number? That's another initiative that has to be which has been talked about multiple times. And yes, that's
and that's been a hang up with national registries of any sort for a long time in terms of donor deferrals and things like that. And my sense is it's a balancing act, and you can put in a number of controls to help in one direction or another, but it's never going to be risk-free. The sense that we had, at least my sense of the way it worked here in Kansas City, was that it was a help, and you would use this as another tool. If it didn't make sense, you would disregard it. If everything else fit, you would use it. So I don't think there's any perfect solution, but my sense is it's better than what we have right now.
Okay, and there wouldn't be any liability on our part what we feed in, would there, or?
Yeah, and that's something I don't know that we can answer that question. So.
So, by the way, this topic has already come up on WellSky's radar. We had a client introduce us to Yale, and we started to have conversations about how this would work. And so some of the things we've been talking about have been the legal aspects of it, the patient matching aspects. So it's one of those things, if you have input on the value here and where you have concerns or have ideas, that's another good topic for me. So
absolutely, the people who are using these people who are using various LIS software, including WellSky, if you guys feel like that's something important to you, then yes, please share your opinion with WellSky to see if
sorry.
Absolutely, go ahead, please go ahead.
So my medical director thinks that it's very important to look elsewhere, especially when we have the opportunity to do it. We have Epic, and I don't know how many of you use Care Everywhere. We absolutely, if we haven't seen a patient in the last 3 months, our policy is to go into Epic Care Everywhere and look to see if that patient has an antibody. And if they do, we honor the antibody and put it in our system. So I don't know how Epic matches with the Epic, because obviously the medical record numbers aren't the same in various Epic groups, but somehow they do, and we use that information. And we have caught several patients that had an antibody that had a negative screen, and yeah, this is very useful.
And think about it, like using it through the Epic Everywhere.
Yeah.
It's like, I'm sure it's painful, like going in there, looking at the results.
It is,
and
because it's not designed for that. So
it's not, Epic does not have a solution for it.
We don't always find it. And they might have one antibody in one place and one antibody in another. And our staff were so excited that they found the JKA that was found in Kansas City that they missed that Houston found a C. Or, it's just like, you could, it's not designed for that, so it's harder. It would be nice if there was a place just to find the antibodies, because that's what we're looking for.
And your hospital has access to Epic. At many places, the blood bank techs don't have access to the EMR at all. Like, they don't have access to Epic or whatever other EMR they're using. They are just using LIS. So having something like that, which
sending the information and not knowing how in Care Everywhere. So how are they? What are they using for their liability of?
Do you have to opt in to receiving and sharing that information, or if you're Epic, you have access to all that,
I think the systems, the individual hospitals have to agree to share their information.
This is really important to get going.
But there's health exchanges too. Like we used Rio in Colorado. I do that.
And Drew, I'm going to ask you because he's from the plasma industry.
Come join us.
Being from the plasma industry, what did y'all have to report to the National Deferral Registry? Here.
Pass it on, Dan.
Yeah, so for the PPTA, which is the Plasma Protein Therapeutic Association, there's a shared deferral registry called the National Donor Deferral Registry. And in that, there's a combination of different things. So it's patient first name, or the donor's first name, last name, date of birth, social security number can also be used in there. And so it's a little bit different because it's all donor information. It actually never goes back to the patient. But that's how it's shared. Another thing that just kind of came to mind is I'm wondering if there's something through Apple's exposure notifications that they did through COVID. So somehow Apple's been able to somehow allow patient data about COVID exposure to be able to come back to you and say, hey, through a series of systems, be able to notify you that you were potentially exposed to COVID, and how they de-identify all that information. And be interesting to know if there's some way of being able to leverage that form of technology for this.
But we had to opt into that system, though, didn't we? This is not this would be potentially the opposite of that, though. So it may not be. I mean, it's a good start, I would think, but it may not be totally analogous.
Right. Yep. That's a good point.
Okay. Anybody else have any questions?
One other thing I will add that, like, in addition to this exchange of information, like concerns with regulatory concern, it's standardizing how we report out the results. Not all hospitals report out the antibodies in the same way. They don't have the same terminology, like the same, like how they report just JKA, or somebody will say anti-JKA, which is the proper way to say it. And how many antibodies are you reporting? So there are a bunch of standardization that has to happen at multiple level, but it's a start, and the registry at Kansas City and other places have shown that it works.
All right, so let me ask a question. So Dr. Mather can take this back to Dr. Hendrickson. How many of you would, if you had an opportunity to be part of a national registry, would opt into that? Okay. How many would not? How many aren't sure? All right, so he can go back and say there is enthusiasm. Is that fair? Okay.
That's what I saw. But can we play it out just a little bit? So let's say there's an exchange and the data comes out of WellSky Transfusion somehow, and it ends up in this exchange, and somehow we figure out that Bonnie Norris and Bonnie Norris are the same Bonnie Norris. So is that exchange a service that you would log in and read, or is there an expectation? It looked like on the chart there was an expectation that that data would come back in a form of an extract and then end up living back in WellSky Transfusion, like it would close the loop. Ideally, you're looking for the data to go to the exchange and back.
Yeah, back and forth, yes.
Not just subscribe to something that I could view, is that right?
Yes, like we would like every LIS to input their results too, so that other hospitals can access that too. Like not just the other WellSky clients, but clients which might be using Cerner, they might still access the data that WellSky has reported out. So that's how it's going to work. Like that's the national registry. Like if it was just WellSky, then like if you take over the market, that will be easy, right?
I think from Nathan's perspective too, I think what he's asking is how do you envision a user in any system, WellSky or otherwise, accessing that system? Do you see it being native within our solution, or something that they look up directly through the registry? That was much better.
Yeah. So I don't know the technical details of, like, they have proposed this, the people at Yale have proposed that they have their own cloud-based registry, which you guys tap into somehow. Like, I don't know exact details of how that works. Like at the Kansas City, there was a registry somewhere, and our staff would have to log into that separately to get that information. And then they can take that information and enter that manually into the system themselves. But like ideally it would be, and like the results, again, like as Dr. Manitov said, like it's not that you have to honor those results done at outside. It's at the hospital transfusion service level, their staff and medical director, they decide that we want to just know this information, or we want to have this there all the time. Because like you can see antibody, and you can, for that transfusion incident, you can take that into consideration and then wait for your workup to be completed and then enter your own results. Or if you trust those other institutions, then you can just not repeat the workup and save money on your end.
Yeah, when we put the registry together here years ago, there was a sense of the hospitals that had familiarity with doing compatibility testing and antibody identification, and others who were less secure in that. And so there was a sense of which results you could put into the registry and which ones you would confirm later on in a different way.
All right. Amy?
Yes.
Okay, I'm gonna.
She's loud enough. Go ahead.
Thinking about one of the things I saw on the slide, you mentioned about this also being linked to like ABO. And ABO is an excellent identifier to know if you've got the right patient or not, if they have a different blood type. How are you going to tie this in with bone marrow transplant, stem cell transplant patients?
So I think that came up like, and like those will be like the initial part will be just do the simple workups, and then like eventually, yeah, that would be all those information. Again, like if this registry, national registry, is successful and people feel comfortable, you will layer up on all these complicated workups, like patients which are getting transplants, patients which are receiving.
Yeah, I think that was the other one of the comments we had in our registry was other, patient comments. That probably would be in there.
One thing is the people who are getting bone marrow transplant are so immunosuppressed they don't.
But yeah, like all those things, like eventually, yeah, like there's so much information out there which could be part of this registry, but the basics will be to start with just knowing if this patient had a simple allo antibody out there, and we are not just giving a unit which can potentially lead to a hemolytic reaction, delayed or acute right away.
And
So
having worked one of those on a Sunday afternoon, I would love to find a way to avoid them.
absolutely, yeah.
And they're ugly.
Right. Yeah. And like the example that I showed here of the liver transplant patient, I would not say that's an extreme example. Those are like routine patients that you see all the time, and like most likely that patient would have, if that patient bled like 20, 30 liters of blood, they would have not formed antibody. But even knowing that information, you would have not on purpose given that patient JKA antigen units.
No.
Yes.
A couple of questions. Hey, hold on one second.
A couple of questions. I'm a Wells guy, new to Wells guy actually. A couple of questions. Are the interfacing or the system specifications all that publicly available? Is that easily obtainable? A second question is the registry. Curious about the funding, et cetera, but that's that we can take that offline. But have you also approached organizations such as HIMSS interoperability to because they're going through a lot of standardization? Have you approached them? What's the word has been from NIH, for example, about this registry? So those are some questions that I have top of my head.
So so look, one of the slides, I'm sure these slides will be shared with everybody, right? Correct. Right, and yeah. So there's the website for that is alloantibody.org. I think that's the site where you can go. It's a not-for-profit organization. I'm not actively involved in it. I was just invited to listen to the calls and provide input. So those specific details, I'm sure if you reach out to them, they will be more than happy to share, and they should share all this information. And I think the NIH was one of the things that they have talked about, getting funding.
OASH was involved in this as well. Jim Berger and his group at the Office of the Assistant Secretary for Health. I thought he was involved in that.
I think so. I'm not 100% sure, but
antibody.org,
please feel free to reach out to them, and your contacts with them, they will be able to provide all those specific details to be used.
All right, any other questions? More? Did someone raise their hand? Okay.
No, Margaret, have y'all collected any alloantibody information in the National Registry?
Yeah, from the American Rare Donor Program, we did an abstract a couple of years ago where when patients came to us or a request for rare blood came, we looked up the patient and saw if the antibodies that were listed matched prior and found some discordance there. So now that's part of our procedure, is to always look up, has the patient come in before, perhaps from another institution or even from the same one, and then look if the antibodies listed are the same or different. So we have caught things just like this. But yeah, I mean, we don't share outside. That's just not part of how we operate. But I mean, this is definitely something important. The concern that I have is what you've described, where whether you use it or not would be up to you. My concern, and I'm not from a hospital obviously, is would the hospital see that as putting themselves at legal risk? Because if they choose not to use it and that it was important to use, is that something that the hospital administration would have a concern over? Because you're not just exchanging somebody's hemoglobin, you're exchanging an antibody. If somebody calls it an anti-D and it was really an anti-LW, and you choose to question it.
So medical directors do that every day.
Yeah.
That's part of their responsibility. Sometimes the workups are not straightforward all the time. So there are sometimes we have non-specific workups and other things. So depending on the clinical situation, do they decide to send the workup to a reference lab to do the full workup, or they cross-match unit and use it right away? So I think that's a medical director decision, I would say.
Yeah, and that's a question that will come up and probably will not go away easily. I mean, my sense would be, what's the standard of care, and that would evolve over time. And it would also depend on how easy it would be to access the registry. So it would, to me, part of what they would have to do when they're finalizing their proposal would it be to address an issue like that, and then how they would stage the introduction of it over time.